Communication in dementia can be really challenging, and one of the reasons for that, as we've talked about, is the subcortical or cortical dementia that the patient may have, and that can affect their comprehension of the speech, but can also affect their production of the speech, or both, and that can make it really difficult for us as practitioners to try and communicate with the patients. So in this video, we're going to talk about some of the pitfalls of communication and some of the adaptations that we can make. Following on from that, there's a nice little video from University College London that shows a patient who is having an interaction in their own home with a healthcare practitioner. Part of this is to watch this video, and then I'd like you to head to the discussion board and reflect on the video and what you saw, what problems there were, but also what you've learned as a student paramedic to overcome some of these problems that you saw in the video. Although this is a district nurse or a nurse practitioner within the video, this could quite easily be a paramedic or a GP seeing the patient in their own home. There's quite a few pitfalls when you're communicating with the patient with dementia. And one of the problems is that if your communication skills aren't great, you can start to lose trust of the patient, which then makes gathering the history and the subsequent physical examination quite challenging. The first pitfall is interrupting, and what you'll find with patients with dementia, if they've got dysarthria or dysphagia or aphasia, so those speech problems, is that when they're talking, they'll be trying to get their words out, but other people will be interrupting them. And for the patient, this can be quite distressing and also can be quite frustrating. So try and give your patients that time to speak. If they are really struggling with the speech, you can of course help them, but finishing off the patient's sentences all the time, you might actually be missing the point of what they're trying to get across to you, and you might actually not be getting the full picture from the patient. What you do find following on from this is that both patient and practitioner can get quite frustrated, and what you get is a situation where the practitioner and the patient can contradict each other and start to argue, and this is really unproductive. What you want to do is try not contradict the patient as much as possible, and don't argue with them, certainly. That's really important if you've got somebody with delirium who says that they've seen something. Usually the best tactic for that is to agree that they have seen it and try and move the conversation on. Never try and dispel what they're saying to you. If they said that they've seen something, you can have a brief chat about it and then try and get your consultation back onto track of what you actually want to talk about. And this goes in line with interrupting as well. Try not to speak for the person. Try and let them speak and give their own history and their account of their problem as well. It can be quite frustrating for the patient with dementia who's trying to get their words out to you, and then you're interrupting them and speaking for them all the time. Give them that freedom of speech. And this comes with a problem as well when you reinterpret what they've said, and sometimes your reinterpretation can be wrong. So try not to say what you think they said, try and say what they said, if that makes sense. So if they're telling you an item from the history, recount it in their own words rather than rephrasing it, because the problem with rephrasing is that they then might have problems with the perception of what you're saying. So try and keep things in their own words. Try and avoid medical jargon as much as possible. And the reason for that is that they might not understand it. And as we should with all consultations, the patient should be able to understand it. So instead of saying to the patient, I'm just going to have a feel of your medial ankle, just say, I'm going to have a feel of the inside of your ankle. And then they know what they mean. Not everybody understands the language that we talk, the medical jargon. And try and avoid talking out of earshot of your patient, because this can lead to agitation, especially in those patients who've got paranoia. So rather than having a talk with your colleague in the kitchen about what you're going to do, involve the patient and make some shared decision making as well. The patient would want to be involved in where they're going to go, and this might help to stop them becoming agitated, because they won't think that you're talking about them and not to them. So try and make those decisions of if you think the patient needs to go into hospital, involve the patient and have that discussion with them, and openly with your partner as well, if that's what you think needs to happen. Try and avoid negative non-verbal communication. So try and get down to the patient's eye level, try and sit by their side and sit so that they can see you. Try and avoid folding your arms and have an open posture as well, because what can happen is that their interpretation of the environment can be different. And what you can find is that although you don't mean to come across threatening by standing above them and having a conversation, to them their perception of the environment is very, very different. So try and keep your non-verbal communication open and include the patient as well. We can make some quite easy adaptations to our communication style to the patients with dementia, and these can really help your consultation and get the patient on side. The first one, what we can do is try and gain the patient's attention. And as we talked about not talking about them out of earshot, try and approach the patient from the front and maintain eye contact. And that will enable the patient to see your face and also the body language as well, which is really important. Try and always use the person's preferred name. And this is really important, and be aware that it might be different to what's actually documented. And be aware as well that they might not want you to call them by their first name. It might want to be Mr., Miss or Mrs. as well. So they might want to be called by their surname. You might also get patients as well whose name bears no relevance whatsoever to what their names are documented as well. So always ask your patient what they want to be called, and this will help your communication with the patients. And remember, going back to the examination, what we talked about, repeat who you are frequently before the examination and interventions. Remember that the attention span might be reduced, their short-term memory might be significantly reduced, and it's not unusual for them to think about something else and then not remember who you are or why you're here, which can be quite frightening for the patients. Remember to reiterate that you're here to help them and keep calm even if they're not. You can find that some dementia patients will become quite agitated, even quite aggressive, nipping, biting, throwing things. Never rise to it. Always stay calm. Reiterate who you are and keep calm even if they're not. And that goes back to having an open body language and not rising to the patient's aggression. And again, slow down and don't rush. And avoid the use of medical jargon. Try and keep it simple so that patients can understand. What you're about to see next is a really good video produced by University College London, and it's about a consultation between a lady called Barbara and a nurse practitioner in the patient's own home. And what I'd like you to do is watch the video and then have a reflect on some of the pitfalls that you saw this practitioner fall into and some of the adaptations that the practitioner could have used. There's a link to a discussion board below, and I'd like you to have a think about what happened, what was the significance of it to the consultation, but also what are some of the adaptations that you've learned and what are some of the adaptations that the practitioner could have used in this encounter with Barbara.
So, Mrs. Rees, how have you been feeling?
Fine, I've been feeling fine.
Sleeping well?
Yes, I've been sleeping all right.
Now, I'm just going to take your temperature, so if you could just pop your cardio for me. Do you like a hand?
Thank you.
Arm up. Now I'm just going to listen to your chest. Breathe in. Right, now I just need to take your blood pressure. So, Mrs. Rees, I understand you phoned your daughter early this morning.
No, I haven't phoned her.
Are you sure, Mrs. Rees? Are you sure? Are you sure, Mrs. Rees?
Yes, I'm sure. Maybe Len phoned her.
You've got to take the racket right the way back. Oh, right the way through. Go on, give it a go. Use the bramble there. Oh, good shot. And another. Well done. Right, race to the tree. Ready, steady, go. Oh, you can come back here.
And I think I'm going to need an ambulance.
Ambulance? What for? What do you mean?
Just a minute. It's all right, Mrs. Rees. There's nothing to worry about.
Yes, but
this is just a precaution.
I need to let Len know. He's not back yet, and he'll be worried about me.
Yes, as soon as possible, please. Yes, of course. I'll get you the address. Okay. Thanks.